My name is Elizabeth Cooper. I am a nursing student in the Acute Care Nurse Practitioner program at the University of Alabama in Huntsville, and today I'm going to be performing a comprehensive diabetic foot exam. To begin the exam, first I'm going to do an orthopedic exam. I'm looking for any digital deformities, any curved toes, hammer toes, any areas where there could be increased pressure points, perhaps on the tips of the toes or the side of the foot. Next, I'll check for equinus. That is a tightened heel cord. So to test for this, you just simply press the patient's foot back. It should be able to go greater than 90 degrees. If it can't, then that could mean that the patient is going to be putting extra pressure on the bottom of the foot, which could lead to an increased pressure point and possibly injury or ulceration. I'm next going to check for the plantar flexed metatarsals. So upon flexing, any of the metatarsals that could be dropped below the level of the other ones could indicate an area where there could be an increased pressure, so area for injury or ulcerization. I'll check the arches. Sometimes they can actually collapse, which is called a Charcot deformity. Looks like this patient has good arches. Sometimes they'll collapse, kind of looks like a rocker bottom, and it creates increased pressure. This can sometimes be misdiagnosed as infection because there could be redness or swelling, but in fact it's actually a collapsed arch and could be the beginning of an ulcer in that area. I'll look for any amputations, either of an entire toe or partial toe. Any amputations are going to possibly lead to pressure redistribution in other areas, which could increase the risk for ulceration. I'll check the extremity strength. Pull back for me and push. And everything would be done on both feet. I'm just kind of doing this for time's sake. Next would be a skin examination. I'll check the tops, bottoms, sides, in between all the toes, and I'll instruct the patient to do this themselves at home as well. Looking for any tinea pedis or athlete's foot, any areas that the patient reports itching or redness, any darkened areas, discolored areas, dry skin, cracking, calluses, checking for any ulcers, any gangrenous areas, any areas that the patient might mention that they've noticed themselves. I'm looking at the toenails for any thickened toenails, looking at the sides of the toenails for any possible ingrown toenails, and just through all this educating the patient on foot care and that kind of thing. Checking the temperature of the skin, both on the top and the bottom. Warmer areas could indicate infection or possibly ulceration. Cooler areas could indicate lower circulation in that area or in that foot. With women, this is not as much, it's not quite as applicable, but looking at any areas of hair loss or any patchy areas. A lot of women use hair removal techniques, so it's not as accurate, but just keeping that in mind. Also going to test the pulses and circulation, so I'll check the dorsalis pedis on both sides as well as the posterior tibial. They should be equal as well as palpable. I'll check for any swelling, varicose veins, especially on the inner aspect of the lower leg. I'll check for capillary refill. So the color should completely return within 3 seconds. And this is an easy thing also for patients to do at home, is check their capillary refill. Next, I'll check their sensation. So first I'll use the monofilament, which is one of the more sensitive tests for sensation. Just light pressure, and this will be with the patient closing their eyes in the first, third, and fifth toe, and the metatarsal pads in the same area. It's important when you're checking monofilament testing to make sure you document the areas that you tested and be consistent from visit to visit, and that way you can get a heads up on where they could be losing sensation first. Any areas where there is decreased sensation, either with the monofilament or with vibratory, could mean that they're in the early stages of neuropathy, which would put them at increased risk for ulceration. I'll also test vibratory sensation. So you just place it on the large toe of both feet. The patient should tell me when she stops feeling the sensation, and it should be at the same time as when I stop feeling the sensation in my hand. If she stops feeling it before I stop feeling it, that could be a sign that there could be some neuropathy going on. I'll also test the patient's dull and sharp sensation, also with their eyes closed, just along various places of the foot, testing dull and sharp, and the patient should be able to discriminate between the two fairly easily. I can also do reflexes. All right, and just to the back of the heel. And back of the heel. Okay. And again, if there is any decreases in those, the reflexes, sensation, circulation, that could be a red flag that maybe some additional testing could be done. You could do the ankle brachial index, the pad test. A lot of foot stores even have where you can go in and stand and find out where the pressure points are on your feet. So that's something that you can talk about as well. It's very important for these diabetics to have education on proper foot care. They need to be instructed to thoroughly wash and especially dry their feet every time they shower. They should inspect their feet daily, tops, bottoms, sides, in between the toes. If they have vision problems or if they are not able to see the bottom of their feet, they could get a family member to help them. It's important to choose well-fitting shoes, not too tight, too loose, too wide, too narrow. Anywhere where there's rubbing or possible increased pressure could be areas where they could get ulceration or injury. If they do have any signs of neuropathy, it's important to wear closed-toe shoes just to prevent injury. Very important to cut the toenails in a straight line, not in a curved formation. That can decrease the risk of ingrown toenail. Important to just really talk about glucose control. Very tight glucose control is going to decrease the risk for neuropathy, retinopathy, nephropathy. Just very, very important to keep that neuropathy from progressing. These patients need to have diabetic foot exams at least once a year. If there's any issues, if they have any abnormal findings, more often is good, whether it be 6 months, quarterly, or even 2 months if they've ever had an ulcer or do have an ulcer, just to stay on top of all that. But that concludes my diabetic foot exam.